So want to thank everybody for joining today. I know that when the subject of an electronic health record comes up, that can be a little bit mind-numbing to people, and especially when they have busy days, like, oh gosh, do I need to catch up on this, or do I really want to go listen to that guy talk about an EHR? So um, it was interesting as I was putting this presentation together, not knowing who the audience would be. Hopefully I've come up with a presentation that, we can have a discussion. And I please ask questions or make comments as we're going through this. I approached putting this together from the perspective of being someone who's been a full-time BHC 25 years ago who wrote notes either by hand or on a computer and typed them out and put them in a paper record file, to somebody who kind of moved through and we had an electronic health record to my past, which before I retired, I was the lead for behavioral health and primary care for the Defense Health Agency. So I was responsible for rollout training um, over 250 primary care clinics in the Department of Defense, and had the ability kind of at that level to really put together, how do we want our electronic health record to work for our BHCs? How can I try to create what I want so it becomes a tool that makes me more efficient and more effective, as opposed to a barrier I just need to get over or jump around? And so I'm trying to come at it from all of those different perspectives. And I see that we do have, looks like, different leaders and supervisors as well as BHCs. So please feel free to make comments, ask questions, and hopefully we'll have a nice discussion today. So on this lead slide, that's my dog, Colby. She tends to be perceived as cute by people. So Colby will be joining us on various slides, so you'll have something to look forward to if this starts to become mind-numbing. Let's go to the next slide. So learning objectives, these are the two main things I hope people would get out of this. So, and understanding and thinking about what does efficient note-taking look like? What does efficient documentation in a useful EHR look like from a BHC's perspective? And to start to think about why it's important to make how that is done standardized, that still allows the BHC to have warranted variants to document different things as on a case-by-case basis, and how that's beneficial not only to them, but for the rest of the team, the primary care providers that might look at that, and setting up that standardization that really allows supervisors and leadership to at least have a bit of a proxy as to what's going on in these appointments. What kind of people are they seeing? Are these people getting better? How can I talk about the value of integrated behavioral health services to other people who are asking questions and are wondering about whether this is money well spent? So those are my general learning objectives. So I thought we'd start out with the idea of just having people talk about, when you think about a good electronic health record, what does that do for you? So just calling out or putting in the chat box, what are some of the core functions of a good EHR? I could sit with the silence all day. So think about it, your EHR, what are some of the core pieces that your EHR does? Not even thinking about it from a behavioral health consultant perspective. Communicating across departments, yep. Sharing information with the rest of the team. Is it simple? Facilitates good care? Yeah, totally. Any other thoughts? Ease of finding what you need, for sure. Has anybody, you can follow your patients, you know who they're seeing, what's going on in their other appointments. Data tracking, huge. right? So, consistent with what you all are talking about, here are some of the core functions that if you were to use Google AI, which I reference here, or any other AI, or just do a search. I mean, there's a variety of different companies out there that will tell you what the core functions are. So, in general, this is kind of consistent with what you were talking about. And, if you have an EHR that's working well, what are the benefits of that? So basically, what's the functional outcome? What are you getting from that? It sort of fits with core functions, but might be a little different. Assists with quality improvement. Patient gets a streamlined, efficient, accurate, consistent episode of care. Gosh, that's what I would hope would be a benefit. Makes everybody's job easier. The patient, if they want to go in and they want to see whatever their notes are, it allows them to do that efficiently. Oh, I don't remember what Dr. Hunter said I needed to do. I lost that behavioral prescription. Let me kind of sign in and see what he listed in the note. Knowledge of the patient's story, being able to quickly look at what's this patient, who have they seen, what's been done, what's the trajectory I'm seeing here. Yeah, so being consistent with what you said, you want to be able to have better care in a more efficient way, make sure you're doing things in a way that is consistent so that you're making fewer mistakes, that you can engage the patient in a way that is beneficial to their health. So, really a good EHR system acts as that primary hub of knowing about your patient, what's going on with them, what's working well, what's not working well, what is the rest of the team doing to allow you to engage with them in a way that hopefully provides better care, the kind of care that I would hope that I would want to have. And so I also think about this from the perspective of a patient as well. So to that end, what electronic health record elements have worked for you? So if you've engaged in an EHR, whether it's as a supervisor or a BHC, what have you liked? Or maybe your system is so bad, you'll have a lot to say on the hindering part. Being able to use templates for documentation, totally. Central information everyone can access without having to read everyone else's notes. Mm-hmm. Yes. Workability. Smart phrasers, filters for chat, for sure. Sure. So consistent with what you all are saying, I was just thinking about, for me, what are the elements in my electronic health record that had worked? And so, yeah, being able to do things easily, being able to know right where things are, having that electronic health record support you to engage efficiently and effectively with that patient, as opposed to being something that you kind of have to work around, um, and that it's consistent with how you're going to look at it, how you're going to click on it. It's consistent with how you want to go through the appointment. Um, and that's not always necessarily the case, right? I mean, we look at least from my perspective, electronic health records these days are a lot better than they were 10 years ago. And yet there can still be some significant problems, especially for behavioral health consultants working in primary care. So To that end, I came up with some elements that have hindered me in the past and things I didn't like. What are elements of an EHR that either historically you've experienced or currently have going on that don't really work for you, that have hindered or slowed you down in your ability to do your work as a BHC or as a supervisor or a system leader? Some of this I may just be preaching to the choir here. So too many options for areas to chart in. Yeah. Where do you go? Drop down sections are impractical, forcing the user to narrate. Can't run productivity reports more than 30 days at a time. Have to manage. Yeah. Boy, what a goat rope that is. If you want to look at trends, you have to go in and, yeah, totally. Anything else? I mean, I think that's consistent with what I've experienced as well. I think this is a big one that what often shows up in an electronic health record for the behavioral health consultant to use is a system that was designed or a format that was designed for specialty mental health. And then you kind of have to work around that, figure out, well, how are you going to use different elements of this? If leadership doesn't get how a PCBH model of service delivery is different than specialty mental health, they might say, well, you need to be filling out all this, and there's not enough information here. Too many clicks to get where I need to be. Oh my goodness. Sometimes it was just click, click, click. I mean, every click, that's a loss of time with the patient. Forced to document information that's not really relevant to what I'm gonna do. And having a platform that's not modifiable. Um, and people will tell you, which may or may not be true, that you can't change that. You can't move this around. There's nothing we can do about it. The programmers can't do anything like that. And I'll talk to you a little bit later about how I encountered some of that as the Defense Health Agency lead and how I partnered with different folks to show that that's not necessarily true. Um, all right. So when I was thinking about, how does a BHC document? I mean, what are some of those core competency skills that you want them to have? I went back to Robinson and Ryder's, how they detailed this as one of the sections of core competency. So you want, and this can be a trouble, I think, especially for, I've seen it the most in people that have worked longer in specialty mental health and are used to writing notes that are kind of in a prose format, that are pretty long, that include lots of detail, and that they're not necessarily used to other people reading. Um, I've seen them quickly get overwhelmed in primary care, especially if they haven't been trained how to do this or shown examples. So a good BHC is going to write a note that is clear, to the point, focuses on what the question is being asked, what's the referral question or problem, focuses on what are the factors that are related to that, can give a small impression, and then here's the plan. So anybody that looks at that note can see that. And it's including the primary care provider or your nurses or your med techs. They know that if they want to see Dr. Hunter's note for this patient that was seen 3 days ago, they can click on that note, go to the bottom of that page, and it's going to tell them exactly what I'm doing with them and what my recommendations are for them to do when they see that next patient. And basically, is the note consistent with the expectations of the clinic? You don't want BHC's note shouldn't look radically different from other notes that are being done. You want to be part of the same community, you want to be part of the same family. Is this consistent with kind of how you think about core documentation skills? You can just put a Y for yes or an N for no, or if you have other things that you think are important, I'd like to see that as well. Yeah, okay. So looks like we're all tracking along the same lines, but at the same time, writing a clear and concise note can be a lot more challenging. Um, I I mean, I remember part of my experience is also going to train BHCs to work in primary care. And helping somebody learn how to think about how to use your electronic health record to prompt you for what questions to ask, what to document. How can you do that with click boxes or auto text so that you're not just writing narratives? That's a skill that can be developed. And most people don't walk in with that skill because most people are used to charting specialty mental health notes, which in my experience look very different than what's going to be in your primary care note. So even though we have this as a core competency, part of this, at least from a leadership perspective, is don't expect people coming in will know how to do this. You're probably going to need to train them. You're probably going to need to show examples, and you're going to need to peer review their notes. I was recently talking with someone in a system. Now, they just started doing things differently, but they had multiple BHCs that were hired. They were given no standardization, no training about what needs to be in the note, how long does it need to be, so you have wide variability in what your BHCs are documenting. So they're changing that. Um, I think as a BHC, I want to know what's the minimum amount I need to document. I want leadership to tell me why that's important. And I want to have the ability that if there are other things I want to document, I'm seeing some warranted variance. I want to document additional things. I have the ability to do that. And I have the ability as the primary user of that EHR for PCBH services, what's not working in that? So, leadership, if you don't already, do you have feedback from your people that are working in the field of what's not working for them? What would they like to see be different? Now, there may already be a solution that's there, but you just don't know about it. Um, Making sure that you have access to expert or master users of your EHR. They will sometimes know that there are parts of the EHR that you can either configure or bring into your note that will make things much easier. Any questions or comments at this point? Okay. Yes, and Colby's still following us, always looking at us. So um, in terms of what needs to be documented, and in terms of the core competencies, this is what my co-authors and I kind of wrote about in terms of general documentation skills. That documentation needs to be more abbreviated than in a specialty mental health setting. You're writing it for yourself and the rest of the team. Having as many pre-existing or loaded text that you can click or check on that pre-populates that. If I know that if I had to write out by hand, just the comments or the things that I'd write for like 20 depressed patients in a row, that wording is going to look pretty similar. So instead of writing it out, how can I have those pre-positioned so I can just go click, click? Making sure that you're using the same abbreviations the rest of your clinic's using, looking at how are your PCPs writing the note. My experience has been that they're not writing out lots of long sentences. They're writing out, words, several words that get the point across. It may not even have a capital. It may not even have a punctuation at the end. Another thing I see BHCs falling into is using psychological jibber jabber. You know, encouraging people to keep it simple, keep it straightforward. And that note really needs to inform anybody who looks at it, whether it is the PCP or the nurse or the medical assistant, or it's a specialist that this person's going to see. They can look at that note and really get a snapshot of what's the problem, what's impacting that problem, what do we think we need to change to help that patient function better and have better quality of life? And then how are we going to help them change how they think and what they do and how they live to meet those ends? And I think this is also, this last bullet here, if I'm seeing 10 to 12 patients a day and I'm having a patient come back 2 weeks later, I, I'm probably not going to remember what I did with that patient. Um, oh, yeah, there we go. David, you've been asked by PCPs to avoid sentences. Yeah, I mean, you want to speak the same language of the community that you're in. I wouldn't necessarily go and start living in France and expect everybody to speak English to me. I would need to learn French, but that's going to be a process for me, right? So to some extent, using the EHR, if you can, to help BHCs relearn how to do notes. They're having to relearn things. And I think it's harder for folks that have been doing this longer and specially. Um, I've also been able to train nurses to be BHCs and to also be master trainers. And I see them pick up the documentation way faster than mental health providers, which makes sense because that's the community they're in, that's the language they've spoken. All right, so this is another thing that I think gets lost, not only by the BHC, but sometimes by leadership as well, that who who's the BHC writing this note for? And we've talked a little bit about that, but if you can in the chat box, who do you think your internal customers are? This is the way I think about PCBH service delivery in general, that we've got internal customers and external customers. And that applies to not only what we do, but it applies to how are we communicating within that EHR. So your internal customers are who? PCPs, reviewers, patients, yourself, medical providers, psych nurse practitioner, yep, rest of the team, providers outside of the clinic. Could be, depending on whether they're in your health system or not. Yeah, your internal customers. And so as the BHC is writing this note, they're writing it for all those people. So that's a skill set and that takes some development. And again, if you don't already have this in place, I would encourage you as supervisors and as system leaders, we'll talk about this a little later, you don't want tons of variability in what your BHCs are documenting. It should look pretty consistent. The same way that it might look consistent if you have 5 family medicine docs seeing the same presenting problem, right? That should look fairly similar. It's going to look a little different because everybody has their own personal unique style. This topic is a lot like designing support systems must communicate in the most efficient way possible. Yeah, I mean, and sometimes EHRs are constructed in ways that inhibit that and don't promote that. So your internal customers, I agree with you. This the same kind of it's anyone kind of within your primary care clinic, or you could argue within your health system, who might be looking at that note. And I think it's not only the job of the BHC who's writing that note to kind of monitor themselves, but my hope would be part of peer review would look at, hey, you're missing this, you're supposed to document this. Wow, this was a lot. Have you thought about this? So not only for peer review, but also supervisors and leaders checking in and looking at what people are writing and making sure, are they documenting what we want? You can call it a quality review, a quality scrub. I think it also, if you're people that are in the clinic day to day doing the boots on the ground kind of work, if they know they're going to get peer reviewed and they know that their supervisor or program director is going to be looking at what they're doing, they tend to maybe pay a little bit more attention to that. I mean, you're always going to have your outliers. But part of that, at least as a BHC, I want to be able to have that EHR and that note not only inform me and the rest of the team, but I want to be able to click through that. I mean, I'm writing my note as I'm assessing the patient as we're putting together a treatment plan. I want that to be easier. And that is certainly not what I had found kind of early on as a BHC. And so, kind of like I mentioned before, I started doing this in 2000. So I'm getting a little long in the tooth. And so things like EHRs weren't set up to promote this. We sort of set up our own templates. Like I said, we did paper notes. We set up, well, here are the things we're going to document. I started even before the EHR was even developed in any substantial way. You know, I would get on the computer and I'd have a pre-printed template of text that I could just delete what I didn't want. So early on, I was trying to figure out how can I make this easier for me, because I'm seeing a lot of patients. I'm getting dragged in a lot of different ways. And that was sort of what kind of prompted me to, when I got into a leadership position, is how are we going to make this, how are we going to make it easier for people to do this? So when we think about our external customers, I mean, those are some of our external customers, and people that aren't necessarily within our system. We could argue whether the patient's an internal or external customer. But if someone looks at that note, does it make sense to them? Can they take away what you're doing? If somebody's coming and auditing you and are going to check, are you billing appropriately? Are they going to say you're committing fraud? It's a whole other talk. So, okay, you know, Chris, blah, 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 blah. What does a note look like? So I thought I'd just put this up as one example. This is an example that we put in our book for folks to see, so that, you know, if folks did have this book, if they're in a system that's not giving them examples, that's not training them, here's what it might look like. I'm not saying it has to be like this, but it gives you a bit of, oh, okay, now I have a behavioral anchor that I can use as a target. And does mine look anything like this? So in this, we've got anybody that looks at this, when I see a patient, they know what the chief complaint is. They know who the referring provider is. They know what the HPI is and the questions I've asked them, so they can get a snapshot of, well, what's been going on with this patient? What's been impacting them? Health habits. See, simple sentences, simple words. You can look at this and you don't have to read through 3 sentences to figure out what's going on with this person. Does this note, and you see at the bottom, we've got the recommendations for the patient and recommendations for the PCP and the rest of the team. So when I pull this note back up and I don't remember who this person is, I can look at this and go, oh, yeah, I remember. Okay, and so they're coming in. So I'm going to check on, you know, the recommendations and see were they able to do those. If not, what got in the way? How do we problem solve those? Did they do them? How can we keep going on, perpetuating that? Does this note look similar or vastly different from your BHC notes? There's no one right way to do that. Each system is going to be a little different. Any thoughts? So if this looks similar to what your BHC note would look like, you can just put a Y in the chat box. If it's not, talk to us about how it's not. What would you add or what would you take away? So this is different than how my BHCs currently practice. Can you talk a little bit more about how it's different? You don't have to,
Yeah.
Lana.
I'll put myself, I'll talk 'cause it's easier than typing.
Yeah.
Um, yeah, I mean, our current system, we use templates within the next gen system, and there's just so much narration. Uh, so we have mostly like a mental status exam that would include a lot of this, but then we have like 3 sections of narration where we do intervention, patient's response to intervention, and then the plan. Our BHCs are not in the habit of writing recommendations for medical staff because medical staff pretty consistently do not read the notes. But I think that they don't read the notes because they're difficult to read. So we're in this sort of catch-22, and trying to work on it.
Sure. Sure. Yeah. And, thinking about when I was doing this as a full-time BHC, I mean, we were required in our system whenever possible to give verbal feedback to the PCP the same day we saw the patient. That's a whole other skill set that we train people on. But some of that is, some providers who say, yeah, I don't want to hear that. I'll look at your note. But yeah, if the note is cumbersome, you're basically punishing your primary care provider and the rest of the team for looking at your note. So the BHC has spent all this time documenting things that nobody ever looks at. What a waste of time that could be different, right? Yeah, the APSO. So having that assessment and plan up front is another way to do this. That can be really effective. That anybody that pulls up the note, they don't even have to scroll down the note. Kind of what they need to know is right there at the top, and then they can scroll down for the history. Again, there's no one right way. Whatever works best for your clinic and your providers, what makes their job easier. But I would encourage you that we could talk about this a little later. The cumbersome record that you're in, nobody wants to look through sentence after sentence. I mean, I've got the attention span a bit of a gnat at this point, and it's like if I have to read more than two sentences, I don't want to read sentences. I want to be able, and I grew up in Texas, so I'm a slow reader anyway, and I process things slowly. So I want to be able to look at it and get bullet points and snapshots that I'm basically look at their words, but they also start to put together a bit of a picture for me. Or it takes me forever. I'm reading this sentence. What are they trying to say? What's the point? What is the important information I have to pull out of this? So, I mean, that might be a discussion that, you have with your BHCs, that you talk with the people that know your electronic health record. Does everything that's being documented, does it need to be that way? Can you change things? Can you alter things? This sounds like a course in writing good emails. Um, you know, David, there's some real similarity in terms of writing a good email, in my opinion, and writing a good BHC note, you know? And it's a skill. You don't want too little information, you don't want too much information, and you want a wide number of people. I mean, when I get really long emails, it's like, oh, okay. When I write my own emails, I try to be really specific. If I'm changing a subject, I'll even put dashes and the word break, a couple other dashes in my email, so people know I'm switching to another subject matter or content. So yeah, the format, I mean, the order that you put the information in there can be whatever you think works. But for me as a BHC, and I encourage you, if you're not doing something that looks like this, phrases, a couple of words, everybody knows where to look for the information. Think about how you might do that differently. How can you change it? How can you pre-populate information? It's a challenge. I mean, even being in sort of the driver's seat, there are so many system challenges to getting your EHR the way you want it for your BHC so that it actually promotes good care and communicates well and allows you to extract data that is useful and that at least serves somewhat as at the very worst as a proxy to let you know what's going on. Here's an example of what I think might be poor documentation. And this is what historically I saw with people that had been practicing in specialty mental health or even kind of consistently with folks that are coming straight out of grad school. For many years, I trained psychology interns to work in a PCBH model of service delivery. So, when I look at this, it's like, wow. I mean, the description of symptoms, well, there's good information in there, but I don't want to have to read through all that. I'd like to see those in bullet points, right? Under maybe subheadings. When I look at this duration of this problem, The patient reports that she feels that she has been feeling depression on and off for years at this point. She reported that her childhood was difficult and marked by emotional abuse as well as considerable marital discord between her parents. Patient reports that at times she feels she never had a chance at a normal childhood and feels that this is affecting her adult life as well. She does feel like her latest round of depression has persisted for about 2 years or so. So the duration of the problem could be listed as ongoing as an adult, more specifically for about the last 2 years is the most recent episode. And the factors correlated with onset, wow, I'm not going to read that to you, but the factors correlated with onset could be father's illness and death 2 years ago and work stress. Having all this extra information for me as a BHC isn't necessarily going to change, or at least having it in the note isn't going to change what I'm going to do with them. I mean, some of it might be interesting. It might help give me context, but wow, that's way too much. And I don't want to have to wade through that. So when you look at this, I mean, do you agree with what I'm saying or do you disagree? You can hit me with a Y for yes, I agree with you, or an N for no. And then if you don't, well, let's talk about that. Okay, so it looks like we're all sort of on the same path, same mindset. I am a big proponent of standardizing how BHCs document in an electronic health record. I think people want to know what their targets or what their goals are. And I think it's important that it's explained to them why they're doing this. So when I was in my leadership position at the Defense Health Agency, we actually put this into health systems policy. We detailed out all kinds of things. So if leadership ever had a question, if BHCs had a question, I don't understand this, nobody tell, well, here's the DHA policy that mandates that you have to document this in this way. And so we had a procedures manual where we laid out for your note, and what we laid out they needed to document was consistent with how we set up the part of the EHR they were going to use. Here's what you need to document. And when we brought them in and we trained them, we discussed with them why we're doing this, why this is important, how this is going to help you as a BHC. And we also solicited feedback from people in the field. You know, we didn't just do this as leadership saying, oh, well, we're going to make these final decisions. We wanted to talk to the people. What's useful for you? What do you want? And oftentimes there, in my experience, there's a big overlap. So, you know, your BHCs that are actually doing the work every day feel like they're being listened to and that they have some buy-in into what's going on. They're not just out there just being told what they need to do. So we produced this procedures manual. And I know this is a lot, but I wanted to just give you an example. This isn't even all of it. So we laid out what the documentation should be, and that this was for all encounters, whether it was a face-to-face or we were in a transition of going from one EHR to another EHR, which is a whole other story that if you ever get me alone, we'll talk about how, well, I'll just be quiet there. But every BHC initial encounter must, it's not an option, it's not up to you not to doc this, must include documentation of, and we listed out what it must include. So here are the BHC's target. This is what you must include. If you want to, you can include these other things. Desired documentation when applicable. So we're saying you can document other things. And here's some examples of what you can document. Screening, here are the screening measures. Here's what needs to be in your HPI. And we created the sections for them to do that. So not only is it, here's the policy, not only here's what you need to do, but we're going to make it as easy as possible for you to engage in your clinical note writing and your clinical behaviors in a way that flows with what policy says you need to do. Um, does anybody have in your systems, do you have documents like this that lay out what needs to be documented, what must be documented? Here's optional. You just give me some whys if you have yes or no's if you don't. Okay. So you're setting up the expectation. We've got some yeses, setting up what needs to be in here. If you're in a system that doesn't have this, it has been my experience that there's some real benefit for that, not only for the BHCs, so they're not having to guess. Yeah, it's been very helpful to have these during the onboarding or training process. Totally. I mean, I think BHCs want to know what to do. I think most BHCs want to do a good job. Um, but if they don't know what they don't know, they may not be hitting the targets that you want them to hit. Right. And so part of it is an onboarding process, it's a training process. Oh, I can go back to this document and look at this. Oh, wow, what they're wanting me to use in this EHR. Well, okay, that's making my life easier. Oh, peer review. Not only am I peer reviewing other people, but they're peer reviewing me, and it's consistent with the policy, and it's consistent with how the EHR is set up. All right. So I've talked about training. We saw this as something that was super important. In our systems, I won't go into the development of the system in the DHA, but we had major sort of shifts in how we would do this, and we found that it was very important not only to have that policy, but to really train new people on how are you going to do this in the EHR. In fact, when we were doing our onboarding training, we have standardized patients, and we'd have the EHR open, and they would bring up a test patient to put this in, but they were documenting as they were being trained. Now, they also had very specific instruction on here's the EHR, here's the tab you go to. They had PowerPoints that they could go back to. So from the very beginning, they were being shown how to do this. And I think this is super important. It allows people to be more consistent. It allows them to document the things that you as leaders think are important. Because if they didn't document it and you go to pull data, you got missing data points, or people are doing a variety of different things, so you can't get consistent data pulls. Part of what I wanted to see, we'll talk a little bit more in detail, but I wanted to see for every BHC that saw a patient that had at least 2 appointments, were their symptoms and functioning getting better, staying the same, or getting worse? And I could pull that across 250 plus BHCs, and I could show leadership for people that present with this, and this, that come back for a second appointment. Now, there's some attribution bias for the people that come back for a second appointment who started off with scores that were in a clinically distressed range. Did they get better, worse, or stay the same? So I could start to make that argument. And that we'll talk about the dashboard in a minute. It looks like you all do, from some of the previous comments, you do have trainings like this. Does anybody not have trainings or hasn't been trained like this? I know that systems are still vastly different, and there are systems that have been developing for a long time and have all this down. That doesn't mean that system stays the same. Sort of like a garden, you have to keep tending to it. And there are some systems that are starting up, and this is all new. So if you don't have something like this, it might be something you want to talk with leadership or other BHCs about. How do you make sure that we're all kind of rowing the boat in the same direction? Why are we doing that? And how is it ultimately going to help us have a better, a more enjoyable work experience, and to use the EHR so that we can engage in the most efficient and effective way with not only the people that we're seeing, but with the rest of our team. So what you have on the screen now is what I was able to initially put together with our legacy system. And so once I got to a leadership position, it's like, okay, we're going to build this the way I want it to be for a BHC. And so what we ended up doing was we were going on an old legacy system in the nobody else had the system, but we had some what I was told were essentially sort of window-like overlays that we could use that could leverage the architecture of that legacy system so that we could do a better job of having the EHR be consistent with what we wanted our BHCs to document and provided clinical decision support prompts, text that they could check yes or no on. And so you look at the very top of this, we spent time with, I remember this, we spent like 5 days doing the initial mock-up of this. And I was in a room with people that were going to build these tabs, people that were coders, informaticists, which could actually speak. If you don't know what an informaticist is, Google that. But essentially somebody who doesn't necessarily do coding, but can speak the EHR language and who could be used as a translator when a coder didn't understand exactly what we were wanting. And so we set up what are the common things that you may see come into a clinic. And we're going to pre-populate. You click on this tab, it's going to be pre-populated with questions we think you might want to ask that will give you actionable information for that kind of presentation. We also had an administrative tab where people could put in a variety of other pieces of information that didn't necessarily fall in a clinical piece, but they could go through all this, or if nothing, if what the patient was presenting with was none of these, they could go to other problem, and it was a generic version of this. So we tried to set it up that allowed them to not only have, some decision support prompts about what to do, but also over here, what questions might you want to be asked if someone's coming in with a sleep problem that will give you actionable information so that you can provide an evidence-based treatment plan, right? I like to call it dummy proof. I don't want our BHCs to necessarily have to remember what questions to ask. But if they're looking at it over and over again, this will train them on what to ask. So if the system goes down after they've asked these questions 100 times, it's sort of embedded. So if we look at, this is sort of, these are screenshots as we continue to go down, different headings. And this was in the day when we were limited in terms of what we could do, but it allowed us to prompt them on what to ask. Here's what you use when you have a follow-up appointment with this person, your assessment tools. Here's where we want you to put your scores. So on sleep, we want you to do the insomnia severity index. We want you to put the score in here, because when you put the score in here, that allows us in this legacy system to extract that data. So we could look at, are the scores changing on these patients? We could pull that administrative data. Is this the first appointment, second appointment? We could pull patients by their ID code. So it really allowed me as the program director, and it allowed all my program managers, we built out a dashboard, and we could look and drill down to any BHC in any clinic and see who are they seeing. So on this extractable dashboard, I could look at a given BHC in a clinic, and I could see in a given month, and we could look back over the last 12 months. I could see what are the patient, what kinds of patients are they seeing, who in the clinic is referring them, what kind of problems, are patients getting better, worse, or staying the same? What are the number of unique appointments that BHC has? How many appointments a month do they have? Do they have a lot of follow-up appointments, or they have an initial appointment? And so again, this allowed it allowed the BHC to take a look, and everybody had access to this. I could look at a BHC's work in another clinic, right? But we get a BHC that says, I'm overwhelmed, I can't see any more patients. Well, let's pull up and let's see what you've, maybe this is wrong, but it looks like over the last 3 months, you've averaged 5 patients a day. So is that accurate? What are we missing here? Oh, well, you're having problems documenting, which is making it hard for you to get through the day. Well, let's address that. We could look at, is a BHC only getting referrals for depression and anxiety? Well, you know, X number of percent of the people that are coming into the primary care clinic are coming in there for a chronic pain condition or diabetes. How come we're not seeing those people? So we could loop right back with, if we wanted to, at a headquarters level with clinic leadership about, wow, you have some real opportunities here. Or that direct supervisor could, if they wanted to, could take initiative on that. So it's good for people at the upper level to see kind of what's going on system wide. It allows you to compare BHC to BHC in a small, medium, or large clinic in different areas of the country. And it allows you, when leadership above you starts to say, well, I don't know, is this really helpful? You know, we're spending a lot of money on this, and we were spending a lot of money on this. You know, how do we know that this is even helpful? Well, let me show you the data, sir or ma'am. Here's the data that we have. And I could show aggregate data for BHCs in 250 clinics. So, you know, it starts to tell a story when you can put the data and then you can also put like a story or a real face on that. But yeah, standardizing the EHR documentation and allowed us to be able to put together that dashboard that was really informative across a range of customers. So my understanding of most modern EHRs is that they definitely have the ability to extract data. I think that's where, if you have an informaticist to help you go over and you can work with somebody who's a master user, you can start to set up your own dashboards if you don't already have them. Does anybody have a dashboard set up that's something like this? And if so, how have you found that useful or not useful? So in my old system, I mean, we went through some very painful transition from the old EHR, where I had access to lots of information, to the new EHR, which, let's just say, when the Department of Defense went under contract with Cerner for the new MHS Genesis, it is my opinion that they purchased a 1986 Honda Accord with roll down windows. Not the best option. 5 years, 6 years later, 7 years later, I spoke to the person that has taken over my job since I've retired. They've been able to take the new system and make it work for our BHCs. And so you can see this is a much more modern looking EHR. Let's see, we've got in the chat, I missed this. Not yet, we're transitioning to ECWBH module and understand they have a dashboard. Hopefully that dashboard is useful. It has been my experience that dashboards may be designed by medical professionals that don't have a clue about what PCBH is, or they're designed by specialty mental health providers. And so they don't know what they don't know. So oftentimes those aren't really the complete solution to what you want. So being able to go in and have the ability to modify or create your own based on what's already there, I think can be a real help. So you'll see on this, we've got it set up so that they've got, you know, HPI, you've got all these areas over here that they can check. You've got pre-positioned text that they can put in here. So these look kind of very similar to those tabs on that legacy system that I showed you. You know, they can click any one of these that can have pre-positioned text. These are all test patients, by the way. There's nothing on here that's a real patient or that would have been a problem. Um, but kind of ongoing, I mean, it can take a while to get the system the way that you want. Myself and my predecessor had put, or the person that took over had taken hundreds of hours doing this, working with informaticists, working with coders, but our whole system transitioned. So we were one on a list of 100, right? And that list keeps getting jockeyed back and forth. And then all the fixes that we gave somehow magically got lost. But that's again another story to be told after work hours. So I talked a little bit about peer review. If you're not already doing peer review, I'd encourage you to do it. It is a way for you to look at, are your BHCs documenting what they're supposed to? It's still a proxy. I have unfortunately during training sat in and observed BHCs who will document things in the medical record that they did not ask about, but that's atypical. So it allows you to see, are people doing what you want them to do? And if not, then they get a reminder of this. And then if you start to see a pattern in peer review, then that you can engage them in a different way and find out kind of what the problem is. Does anybody have a peer review form that looks like this, that is sort of tracks your EHR or reflects what they're supposed to be documenting? You have a no. I would encourage you to think about that. I think it can be useful for the BHCs. It's sort of like you get a reminder, oh gosh, I've been missing this. What's going on here? How do I need to fix that? We got a yes. Lana, what if any has been a benefit of, from your perspective, of having a peer review form?
Yeah,
Yeah,
the peer review is useful, I think, just for it kind of serves similarly to the documentation, like sort of policy that you had, but in this sort of grid format. I love having trainees do a peer review at the beginning because it helps them understand what is necessary to have in the notes. And they seem to really learn from it a lot. It's kind of like testing someone to teach them.
totally. Yeah. I mean, I think especially for people that are new on that, I know as as a busy BHC, I'd get the peer review form and I'd go, oh God, okay. And I'd go through and because I'd have to pull up somebody's note. I have to go into the EHR, I'd have to pull up somebody's notes and I'd have to do these. I was assigned at one point with, different folks to go in and check. And so, that's a lot of extra time and effort. And so, as leadership, making sure that, you talk about what's the importance of doing this and making sure that if you can, that you block out administrative time for your seasoned BHCs to do this, or else it becomes sort of a punishment and they'll just kind of, we used to call it pencil whipping. And we used to do peer review back in the day with an actual piece of paper and a pen. It wasn't electronically done. So yeah, if you're not doing peer review, I'd encourage you to do it. And you just heard that there are some real benefits, especially for folks that are just being trained or just learning this. So that's all I had for today. We still have plenty of time if people have other questions or want to discuss anything. My email was on the beginning slide. If you want to contact me, if I have any questions, want to have any discussions afterwards, it's clhunter1313@gmail.com. I'm happy to get together and answer any questions offline if you want to do that. But yeah, open things up. What questions or comments do you have? So Ton, you said yours seems more lengthy and reflects the entire chart. So I'm a big on the peer review. I'm a big proponent of. Now I don't always hit this, but I'm a proponent of don't ask questions or don't review things that aren't actionable or don't have an impact, right? So if it reflects if your peer review reflects the entire chart, what's the benefit of that to your BHC or your system or other people? And if you were to redesign it, what would be the things that are really the must? What are the peer review things that you think are important to document that make a difference for that BHC, for that patient, for the PCP and the rest of the team, and for leadership? Questions, comments, discussion. Not seeing anything in the chat.
Thank you so
And if
much
you
for
want
this
to come,
helpful
go ahead.
and wonderful presentation. I really appreciated like the intentional focus on like value within your note because I think we have a challenging time with some of our trainees and like getting them to like pare out the jargon and be really specific.
Yeah,
One question I had was about like item or measurement selection. We're in the process of trying to build a similar kind of registry or like database to help scale outside of like our resident only clinics because we have I'm at Henry Ford. We have psychologists in our like resident driven primary care clinics, but we haven't expanded our PCBH model outside of that just because of volume. And I also think this is a really important thing from our statewide process. In this group before, I've talked about like our collaborative care models are part of value-based care initiatives, but the PCBH models have not been allowed in yet. And I think this is a way to help us do that. So I was just wondering from you about like why you selected which like objective item or which objective measures you use and like how you're going to went about that process.
sure. So I think that's a really good question, and I think it's a challenging one for people to, how do you pick a measure that is given for every patient at every appointment that provides good information and is applicable, right? And so when we were thinking about that, we looked at a bunch of different measures, and we had been looking at the Duke, and yeah, the Duke was helpful and it sort of applied to folks, but there's okay, what's the scoring algorithm, and is that taking up a lot of time? So what we ended up doing is we ended up going with the behavioral health measure 20. And we did that because we thought it could really apply to any patient presentation because it looks at functioning, quality of life. It's got a suicide risk screener in it. It looks at your general mental health stuff. And really, regardless of what anybody's coming in with, it's probably applicable to most, if not all, people on any appointment. Now, the catch with that is that the BHM20, the owners of that, it's a proprietary tool. And so they had their own scoring algorithm. So what we did a one payment contract with them. And so what we said is we're gonna pay you, how much do you want for us to have a perpetual license to use the BHM20 for every single BHC in our system, which at that point I think we put it at like 314 or something like that. You're going to give us your scoring algorithm. And so we did that. We paid a one-time fee. It was a big fee, but that starts to become micro cents per patient over time, especially in a large system like ours. So you had perpetual use of the BHM20. So if it ever changes or updates, we get that use. We have access to their scoring algorithms. If that changes, we get that. We took it wasn't optimal, but it was what we could do at this point. We took some of our data people, and what they did is they built an Excel file where our BHCs could just put the score on each question into that Excel file, and that it would use the algorithm and it would push out all the things that they could potentially put in the note. And then we have in the note all the BHM20 things you're required to put in these, but you can also put these in if you want, and they could track that. That wasn't optimal. Ultimately, I'd want something that a tech or a medical assistant could take and put in that before I stepped in. So it was already pre-populated. That ultimately would be what I want. But that's what I'd encourage you to do. I haven't looked at the Duke in a while. The Duke is something that probably may be more affordable, but then again, how do you incorporate that scoring algorithm? Do you have a tablet? I mean, I think leveraging the people in your system, but that's what we did. And so, it was required. Every patient, every appointment, you have to give them a BHM20 and you have to enter it in the electronic health record, because that's how we're going to see change for every patient that you see 2 times or more. Are their scores changing? If I don't have that, I don't know. Are they getting better, worse, or staying the same? And if I can show that people are getting better in comparison to their reference group, I can start to argue my value for BHC work. If I can take a cohort of the same people in another system that don't have that, can't really give them BHM20s, but can I look at other proxy indicators? If I were seeing someone for diabetes, can I see all the people that we're seeing for diabetes by the BHC? And is their hemoglobin A1C changing, right? If I wanted to use that, well, I could compare that to another group of similar people that aren't seeing a BHC and see, is that different? That's not perfect. That's not necessarily the best science, but we get the information we can get and we do the best we can with it, knowing that it's flawed. And so, we have, I say I don't work in the system anymore. I'm retired. Data on thousands of patients that I could pull up and I could look. I could look at patient X and I could see you've seen them 3 times and they came in for this problem. And here's how their BHM20 scores changed. Well, if leadership wanted to know what's the valuable, I just have my data guy just show me what's going on for people that come in that meet a distress level. At one point, we were looking at everybody, but we decided to take people out that weren't showing scores in a BHM20 that weren't in an elevated level. Because when you're looking at averages over, I mean, that's dumbing down the people that would actually you've got a floor effect there. Those people aren't going to really change. They might get worse, but you're not going to see an improvement in that score because it's already pretty low. Did I answer your question?
Yeah, you did.
Okay.
Because that's like I've been in many conversations with people about why we can't only use the PHQ. That is what our health system uses for everything, and it's not a great measure for what we're actually doing. So it's helpful to hear.
Well, and to that end, I mean, we didn't prohibit our BHCs from using a PHQ-9. If someone's coming in with depression and you want to give them a PHQ-9, fine, give it to them and then put the score in the EHR and we can track their PHQ-9 scores as well, right? And so can you. But you have to give them the BHM20, and the BHM20 has a component that looks at depression. So what's the value added to that? And yeah, I've seen that in systems over and over again. Everybody gets, a screener for the PHQ and the GAD and an audit C. It's like, why are you giving that to everybody? I mean, is it really appropriate? I mean, if you're doing case findings, sure, but you already know what the referral question is, right? That person isn't coming in there or you're going to find it out pretty quick, right? Within the first couple of minutes, what's the problem you're here for? Well, then you have tools that you can, individually give. But yeah, it's a challenge. I mean, we were in a spot where we could do that, and there was a big money outlay for that, but that was like 10 years ago. So, I mean, if you really look at all the administrations of those, I mean, we're looking at, one of 100,000 of a cent per measure at this point. I mean, because of the scale. It was huge. If you're in a smaller system, that scale is going to take, I think, longer to get to. But I think it's something that, it's not easy because things are proprietary, but I would encourage you all, and maybe if I don't know if Naftali's still on here, but whether it's, Collaborative Family Healthcare Association or other people that have an interest in integrated care, put together a group that in a nonprofit way can come up with a measure for integrated behavioral health that is both clinically useful, easy to administer, provides data that's actionable, and shows patient change. Now, you could draw from items in different measures, and then you'd have to run that research to see what are the different parts of validity of this, and that takes some time or money. But at some point, and I'm not in a place where I can do that anymore, if I don't have it, leverage your peers and your network and create it. But that takes time and effort. But I suspect if you look at a bunch of different systems, you have people, if you come together, you could potentially do that. I mean, it's a really important question to have a good global measure that can show change on a variety of different factors for any presenting problem. And we saw the BHM20 as the best one out there that we could use at that point.
Thank you.
Yeah. What else? I've been jabbering on. I got excited about stuff. All right. Well, it looks
I have
like there's.
Oh, I have a
Okay,
quick
go ahead. Yeah.
I was just wondering if, because I had to step out for a warm handoff, but I was wondering if anybody has been making any efforts to collaborate with other members of the treatment team to standardize the method of charting. Because we're trying to look into that in our organization in terms of just having standardized ways of charting for the primary care team, but that can also include for the MAT program or for care coordinators as well as BHCs.
I could speak to historically the way that we did that with sort of the new EHR record that came up is that there were subgroups that would get together that included the people that would be using those records, as well as other system leaders. And so the way the charting and the way the electronic health record was set up was based on, not only what this was like for primary care providers as well as BHCs. I had the opportunity, because I was interested in informatics and healthcare records, to be involved with groups that kind of do this. And it's a long process, but basically you get, what are your stakeholders? Who are your people? Making sure that you have your nurses, your medical assistants, the variety of different primary care providers, whether they're, NPs, PAs, physicians, do you have physical therapists that are in there? Do you have, PharmD? You bring them together with the people that can either transform or have the authority to make decisions about how are things going to be charted. In a perfect world, what's the information we'd want? What does our system have that allows us to do that we can start doing now? What does the system not have that we could potentially change? How long is that going to take, and what's it going to cost? Right? So then you have what's being documented, driven, at least in part, by the people that are actually doing the documentation and the people that should have the clinical ability. And then you have the other experts that have the ability to set up that EHR so it works with your standardized flow from the time that patient steps in the waiting room to check in for that appointment to the time that they leave. Because it's informed by everybody in the clinic, and then beta test it, right? You go out and, okay, here's how we're going to chart what worked. What do we need to keep? What's really problematic, and can we change that, or do we need to just axe it because it's just not useful? We thought it would be useful, but not so much. That's sort of the approach that we took. And so I'd encourage you to, whenever you're looking at that, make sure, if you're not already doing so, include all the stakeholders that will be documenting or viewing that documentation, right? Anything else?
I was just about to ask, do we have any other questions for Dr. Hunter or comments? Dr. Hunter, do you have any last words before I thank you so much for your time and expertise?
I guess parting comments would be, in my experience, delivering good primary care behavioral health model services, doing it well is hard. There are lots of different components. There are lots of areas, from coding to billing to your personnel to your EHR to having a team that works well together. Partner up with people. If you feel like you're alone, look in your state, look in your system. Know that this is an ongoing walk in a valued direction and not a sprint to a finish. And even when things are the way that you think they need to be, don't take your eye off it. Things can change, systems change, leadership changes, new priorities change. But just to know that sometimes this feels hard, it's because it is. It's hard. It's hard being a good BHC. I'd come home, I'd just be exhausted, right? It's hard being a good leader because you're having to meet different people's expectations. It's hard to collect data. A comfortable, slow walk in a valued direction. Because when you try to do a sprint to a finish, that gets really tiring and it's not very reinforcing. So try to take small wins along the way. And, if you can partner with other people at different conferences within your system, do that. So know that you're not doing it by yourself. That's
Well,
it.
thank you. Thank you again. And thank you, participants, for joining. You will get your email with the survey. Be sure to fill that out so you can get your CEUs. And we hope to see you at another session in the future.
All right. Thanks. Thanks for the invite. It's been fun.
Thank you so much.
All right. Bye.